Hello, my name is Dr. Paul Riley from the scientific marketing team at Diagnostica Stago, manufacturer of instruments and reagents for coagulation testing and anticoagulant drug monitoring. I would like to present an honored speaker who will give a special presentation for pharmacists on heparin resistance in honor of National Pharmacy Week. Our speaker today, Dr. William E. Dager, practiced as an acute and critical care pharmacist specialist at University of California, Davis Medical Center for over 35 years and is the past PGY2 Cardiology Program Director. Dr. Dager holds two academic positions as clinical professor of pharmacy at the UC San Francisco School of Pharmacy and clinical professor of medicine at the UC Davis School of Medicine. In addition, he has 4 fellowship honors and is a board-certified pharmacotherapy specialist. He is one of only a few pharmacists recognized as a master of critical care medicine. After receiving his PharmD, he completed a residency at UC Davis Medical Center and later a nephrology pharmaceutical care preceptorship at the University of Pittsburgh. His focus has included comprehensive service-based pharmacist responsibilities for various acute and critical care settings, including the medical, cardiology, cardiothoracic, and other critical care practices, including burn, trauma, transplant, and emergency intensive care, along with selected pediatric populations. Dr. Dager's research interests focus on anticoagulation and hemostasis, critical care, cardiovascular disease, along with pharmacokinetics and pharmacodynamics. He has authored over 140 articles, book chapters, and scientific reviews, and his publications have included collaborations with medical laboratory professionals, highlighting the specific role of laboratory testing and standardized clinical protocols, especially for evidence-based anticoagulation monitoring and measurement, along with heparin resistance. Dr. Dager, please go ahead and share your vast experience on heparin resistance with our attendees today. Thank you very much.
Thanks, Paul, and it's a pleasure to chat with you. I've always had a passion for the collaboration between the pharmacy and lab and learned decades ago how critical that is. I can tell you my foray into anticoagulation care really started when I was put into this responsibility of solving the dilemmas we were facing our institution relative to patients on anticoagulation care in the acute care setting. And I remember jokingly many years back because the INR had just come out. And when I was tasked with this, I had to say to myself, what is the INR? And there was individuals in the lab who helped me understand that. And at the same time, we learned the importance of collaborating to understand how you apply the test because I'm the pharmacist advising the medical staff on how to manage these patients. How do I take the test? Well, spending time in the lab as a pharmacist and collaborating with the lab opened a whole new world to me about the importance of understanding the numbers of the test and not just take everything as this is a number and this is what it means and here are the ranges and this is what I should do. It's so much more than that. So I'm going to spend a little time talking about how this kind of works in the realm of heparin resistance. So I have no relevant financial conflicts of interest to disclose with the material. In general, I have really no really interests or financial interests involved as a component of my career. So let's start with the case. Now we have a 45-year-old male who's admitted for a new venous thromboembolic event. His baseline APTT is 30 seconds and his anti-10A is less than zero point 0.1 units per ml. He started on a heparin infusion with a 5,000 unit IV bolus of heparin, and the infusion then set at 18 units per kilogram per hour. Over the next 2 days, the heparin dose is titrated up to 30 units per kilogram per hour with minimal change in the APTT or anti-10A from baseline. An APTT, anti-10A, and thrombin time are now done 15 minutes after heparin bolus with no appreciable response. We'll come back to this case at the end of the presentation to kind of dwell on what would we do and how does the lab play into this. So we're talking about heparin resistance today, and there's also with this the same dilemma. Many for similar reasons relative to lab is also we sometimes deal with parenteral direct thrombin inhibitor resistance as well. And to us at the bedside, it means that the laboratory numbers are not matching up with what we're giving to the patient. And we don't know if we're treating them or not. So we're seeing a lack of some sort of measurable response. Now, sometimes this can be just a single test. In the case that we gave, we had the anti-10A and APTT because in our institution, we actually do both as a baseline, knowing that times one or the other may not be as reliable. But other institutions, especially smaller rural hospitals, will typically just choose or test one specific agent or lab, whether it's the anti-10A or the APTT. But you're not seeing some sort of response. And we have to keep in mind that none of this is a singular driver. There are multiple drivers. It could be something involving the patient, something relative to the laboratory and their assays, or it could be a pharmacy issue where heparin was not even provided to the patient or a sufficient amount. So we have to always keep in mind that in selected settings of acute thrombosis, there is a need for sometimes higher heparin dosing requirements. And so sometimes it does take us a little bit more to get a response. But keep in mind in our case that we had almost doubled the dose and still saw no measured effect. And 30 units per kilogram per hour is a pretty hefty heparin dose. So, what are some of the potential causes? Well, as you can see, I've listed several, not all of them, but more the common and even some of the atypical ones. There are binding issues with heparin related products that might, in a sense, create a situation where the heparin's not exposed because a lot of times it's free drug that we know is the active component. And it's more common with heparin and may not be seen with other agents like the low molecular heparins or fondaparinux. Probably one of the more common patient-specific ones is antithrombin deficiency because antithrombin is a catalyst that heparin and low molecular weight heparins require for them to have activity. This is one of the reasons why people have kind of said, well, when you use something that doesn't require antithrombin, what we call a direct anticoagulant versus heparin, and these are called indirect anticoagulation, is because of the role of antithrombin. Now, here's one of the little quirks we kind of run into. As an example, as I mentioned, you have a hereditary antithrombin deficiency and acquired. When we give peg asparaginase as part of our chemotherapy regimen to wipe out the immune system, uh, this drug actually causes, in coinciding with it, a depletion of antithrombin that occurs for about 1 to 2 months. And then during this period of time, patients don't respond to heparin. So it's not something for a couple of days. It actually lasts for a period of time. And then gradually the antithrombin recovers and the drug or the acquired situation is over. Just one example, but there's many others. We have platelet interactions where platelets bind up to the heparin. We're also dealing with a syndrome called heparin-induced thrombocytopenia, where we're seeing thrombosis form in the presence of heparin. So the patient, in a sense, is clotting even though I have heparin there, or they're resisting the activity of the heparin, but more so it's the immune mediated response that's overloading any sort of anticoagulation response you see from the heparin. We also have acute phase reactants, as you can see from a laboratory perspective, that might affect the APTT as an example, and we'll talk about others in a few minutes. Also, if we gave some sort of reversal agent that blunted heparin, in this case, we have protamine, but that lasts for a short period of time. The more pertinent one would be the administration of andexanet alpha, which can blunt the effects of low molecular heparin. Even though it's a drug intended for the anti-10A DOX, it would have effects on these agents as well. This is a thing from a pharmacy perspective or nursing, where sometimes they turn the drip off and they forget to turn it on and they measure labs. Well, there's no heparin going. Or if the bag is made by pharmacy, and this is more common in pediatrics because we have pre-filled bags now, but somehow heparin was never added to the bag. So you have to think of the big picture of all the potential things that could cause this. Or it could be incorrect sampling. You could have a sample from the wrong patient. You could have factors that are lowering the measured response. This is a laboratory challenge, and sometimes I'll share with you that clinicians don't have this on their radar regarding clinicians at the bedside. What if the sample sat in some sort of basket in a remote spot or never got into the basket to be picked up by the lab or even sent to the lab for hours upon hours? How do we really catch that? And if they have the timing written on the tube, maybe the lab could catch it. Hey, this has been 7 hours since it was collected. These are things that are going to fall in the lab to try to bring back and says we can't run this sample for the fact that we can't rely on the number. And I can't tell you how many times I saw samples come unable to. The lab just posts that it's unable to measure something, but we don't know why. And we have to resample, and it can be frustrating in trying to wait for numbers to come back so we can adjust the therapies. So when we're looking at confirming heparin resistance, one of the things is it an assay issue? I'll tell you that many times the bedside clinicians are not even asking this question because they really don't know. Many of them trust the lab as being uh, like their chemistry labs in their early training. You believe the numbers no matter what. And they have little discretion on the fact that there could be challenges with the number or what's going on with the lab. So it's important that the lab reaches outside of its doors and get to the clinicians and educate them on these labs instead of saying, we can't do it. Well, that doesn't help me down the line. It doesn't tell me what we're doing or what I do next. So it's important to have that dialogue and that relationship. I do encourage you to reach out to pharmacy more and more if in your institution they're involved heavily with the antithrombotic management. But you have to think of the whole team. We'll cover that. If they're not showing a response, one of the tricks for heparin resistance is use a different lab. So, we might have just one of these labs available, but usually the APTT or anti-10A, but we can do an ACT sometimes that's happening during procedures. I use the Thrombin time as my first go-to. Most of you should have it. And I do recognize that that's on a time basis in many of your institutions that you run them in batches, but there may be times where we're not believing what's going on with heparin with acute clot, when we may call the lab, and it's important to know how to call, who to talk to, and such, and see if we can get a thrombin time either added on to what was sent or redo it, as I'll talk about in a moment. And also, we have viscoelastic testing, the ROTEM, the tag, or there's also newer techniques of doing this to get a better global picture, but we're at least we're trying to find out, is there any sort of anticoagulant response going on or not? Helping me to understand, is it the drug patient issue or is this a lab issue? So the trick that I use, and noted this in the case, is when we give a heparin bolus, it supersaturates the system. We don't measure it right after a bolus because it's going to be off the scale. So if I did this 15 minutes after a bolus, knowing I'm getting the full response, the peak response is there after giving it, I should see something. And if I don't, then I'm going to think that it's not necessarily maybe a lab issue. I need to look at other ways to see how I get this patient anticoagulated. But it saves me maybe a day or two of just going up and up and up and up until we get to these high numbers and nothing's happening and we're still not treating the patient. In acute thrombosis, nothing in the first 1 to 2 days is critical for preventing recurrent thrombosis or extension of the thrombosis in our patient. Again, these are the things we go through our checklist. Are they getting heparin? We may even ask for an antithrombin level because we may be suspecting if it's hereditary acquired that's present. And then we're going to other things is the assay. What was the time to get things measured? Was there inadequate centrifugations? These are things that you guys are very much aware of that might mess up your labs. The anti-10A, if you have a high T-billy, is this going to affect the chromogenic nature of running the anti-10A where you don't get a response? Or the acute phase reactants, as I mentioned, for the APTT or fibrinogen when they're increased. These are things that I'm sure I'm talking to the choir here, but you know it, but do the other clinicians know it? There's a good chance they don't or don't understand it. So this is a piece that is in the anticoagulation form excellence place. If you just do a Google search for anti-10A and APTT, you'll probably come up with this. But it's a piece that I put together just showing to clinicians all the different things that can affect these two labs. And it's important that they have an understanding of it. So if you're trying to explain it and you want a resource to tell the pharmacists and stuff, here's a site that they can go to and gives them more of an explanation. And actually, on this site, talks about transitioning from the APT to the anti-10 in your lab and how to do it. So if you're also going through that process, this is a great resource for you to tap into. But it is really helping us understand these labs, and one do better than the other because neither of them are perfect in what we want to do. And it's also important in the interpretation results to understand what could mess it up. And do we understand if the ACT, even if you looked at the literature, it's amazing that they say, well, we did an ACT, but not recognizing that there's two calibrator ranges, a high and low. And so which one is involved? Even the literature does not point out enough specifics on the labs to understand what we're looking at. And as I mentioned, there are the alternative tests that can be used if we can't use either of these. So this is the key point. It's a multidisciplinary process. The physicians need to understand because they're leading it and taking the ultimate responsibility. And it could be several physicians from hematologists and surgeons to internists, whoever's really driving the ship, but others who are also providing insights as far as how to manage the patients. Laboratory is critical to engage in this process and pull themselves away from the confines of the lab and get to understanding what's going on at the bedside. It doesn't necessarily mean you have to be there, but I would also recommend that as a laboratory personnel in your training to spend a little time at the bedside just to see what happens so you can understand how to best provide your role because you're the experts on the assays. And again, you have a role in educating clinicians or providing insights or guidance on how to use the assays and when they can be drawn and how to do it appropriately. What other ways can we measure the heparin response in a time sensitive manner? And this is where sometimes we're in a rock and a hard place. They may be bleeding and clotting, and we don't have 8 hours to wait for a result to come back because we're making acute decisions that sometimes are life threatening. So in these situations, it's important when necessary, which is hopefully not too often, to have the ability to utilize the lab in an appropriate manner that allows us to get good information to make timely decisions when we're really in those critical, urgent such settings where we need to make the right decision and we need to make it now. Also, pharmacy and awareness of how these all work, because a lot of times we're taking the laboratory result, applying it to the pharmacologic therapy, the anticoagulation regimen, amongst everything else, because we're looking at organ function and things that affects the elimination or distribution of these agents. We're trying to put that all together and come up with a decision on the next step. And the physicians are more and more turning to pharmacy for advice on that as they're so busy. So here's a reason why pharmacy needs to be involved. Another key thing to mention is when assays change and we have order sets and things on different things. And I'm going to take the APTT as an example. When you change the reagents and it changes the numbers drastically, do we even know this at the bedside? Do we have enough advanced preparation? We have all these order sets and everything in place. So what the lab's reporting, what the order sets may be set to do, may be completely different things. So it's important to have this discussion as laboratories changing assays, numbers are changing such with all the individuals involved in oversight for anticoagulation therapy in your institution, and the lab should be present in those discussions. Nurses need to be aware on how to manage and adapt to situations, especially when they're sending samples and also when you're reporting a critical value. How is it dealt with? And the systems and the general overall whole, because we have these Joint Commission safety goals and such relative to anticoagulation therapy, highlighting the importance of being astute in its management. This is a class of drugs most commonly associated with admissions to our ER, admissions to our hospital, and drug-related complications within our institutions. So it's not a minor thing. It's actually a big thing that's on the radar. And we do get in many cases benchmarked on how we perform. And many of those benchmarkers are based on laboratory results. So alternative management. So here's what we're going to do now at the bedside when we can't seem to be getting a response. We may look at the assay, the antithrombin, and try to figure out why. We may need to change the assay that we're using. And this comes into play for smaller places because what if they have the anti-10A, but they no longer provide the APTT? What are we going to do? So one of the important parts from a laboratory perspective is to be aware of this so that when that question does come to you, you at least have an idea or what kind of test you have available, how to do it. Send outs for these kind of infusions and heparin infusions are just going to take way too long to get responses because usually we like to have the information within an hour or two at least, or at a minimum, to manage this therapy. Also, we may have to go to maximum doses. We keep on going up to doses, but we have to keep in mind, is there something neutralizing the drug? Do we have to wait for the antidote to wear off? And then we have to sweat it out because we have a new thrombosis and we're not really treating the thrombosis. And pulmonary embolisms, for example, you can be dead in 15 minutes from cardiac arrest if you have a massive PE. So it's no light situation to sit there and not be able to treat an active acute venous thromboembolic event. Also, we may need to change to a different class of medications. And this is where pharmacy and formularies becomes more engaged because they're going to be implementing these different agents. In acute thrombosis, we're not going to use warfarin, that's long term, but it can be used, for example, in patients who have antithrombin deficiency long term, as well as the oral direct anticoagulants. But we also have parenteral direct thrombin inhibitors to use. So we're going to try to put this all together and also keep in mind that devices and such can be present, such as ECMO or extracorporeal life support, where we're bypassing the lungs and the heart or the lungs, cardiac bypass during surgery. We might use one of the parenteral direct thrombin inhibitors, such as bivalirudin. And then there's antithrombin supplementation to actually replace the antithrombin. This is a complicated process in the first place, and it's super, super expensive. So these are things that we're going to work through as far as how we want to do it. I've not been impressed with giving antithrombin too much. It seems like my heparin dosing requirements don't change much. But it is another way, and there has been some benefits for it in certain selected populations. So let's look at ECMO for a second. Now, ECMO is a circuit that we use at the bedside. It can go on for weeks at a time, but this is where we're resting the heart and the lungs if we use what's called VA ECMO, and VV ECMO is resting the lungs only. But this circuit chews up antithrombin, and you get low antithrombin levels as a result of it. So hence, we get to these patients at times, not all the time, it's not super common, but every once in a while we get these patients where they're not responding to the heparin therapy, and we have to do something different. So I'm giving you, in this example, a type of place where we see acquired antithrombin deficiency that's occurring from a device. And as I mentioned, you can give antithrombin. Now, FFP has it, but it takes a lot of FFP to get enough antithrombin on board. Name any risk taco or trolley. But with this, sometimes they'll use it because they're giving a little antithrombin to see if it does much, but it may take a bit to get it up enough. Depends on how low the antithrombin level's going. And we honestly don't even know what number causes heparin resistance, but it may be in the 20 to 30% range, but it's really unclear. And it even gets less clear in pediatrics. But there's some trials done where the doses are variable for measured levels, and it's all about also additional timing, bolus, and continuous infusions that are going on. So it's really not a strict, hardcore science that we fully have a grasp of. So in the case of ECLS, even when we replaced antithrombin and measured the levels and got the increased antithrombin, we really haven't seen any change in the heparin dose. And there is some data in adults that may actually cause harm and increase failure of the circuit. So this is not necessarily a go-to in adults, pretty much for sure with us. but in pediatrics it might be. But again, getting antithrombin, that's going to involve pharmacy because it costs and expense, and there may be other ways to approach this. So that includes the alternative anticoagulants. The parenteral direct thrombin inhibitors is probably the most utilized approach here. There's two of them on the market, bivalirudin and argatroban. Institutions may have both, but many just have one or the other. And they're unique in how they're doing. But look at these dosing ranges for them in these situations. So it's not really completely a great science, but we do know, and we're gaining more and more experience in using these agents for alternatives to heparin, especially in a situation where you have potential resistance that's going on. You're just taking anticoagulation from a different mechanistic approach. And here's the example of bivalirudin. There's more literature than this, but it gives you examples of how we gain in this setting of ECLS, but also we use bivalirudin in cases where uh, it's not even ECLS, it's an alternative to heparin. And some institutions are finding that it actually is a little bit more cleaner and easier to use than heparin, and have started going to it as a mainstream drug for parenteral anticoagulation. So this is an area that is expanding, and also we're getting more confidence in using it. We've had a fair amount of experience in using bivalirudin in ECLS, and especially in heparin resistance, or also in the setting when we're suspected of heparin-induced thrombocytopenia, where you can't expose the patient to heparin at all unless it's very rare situations in the operating room. So let's go back to our case. So we have a 45-year-old male with a new clot and a VTE. Now, it could be a DVT, a deep vein thrombosis, a pulmonary embolism, or both. Frequently, a pulmonary embolism in some form or way is kind of evident in the majority of VTE cases that are diagnosed as a DVT. We have normal APTTs and anti-10As at baseline, but we have both of them here. Again, you may be dealing with just one, where you have to maybe do the other if one is not responding. And a heparin fusion has now been titrated up to 30 units per kilogram per hour with no response. So I'm now going 2 days not knowing if my patient is even getting any sort of response to therapy at all. Here's where we start going to alternative tests. We might do a thromboelastogram to see, or what we call viscoelastic testing, to see if we're even getting any sort of anticoagulation response or what's driving this ship. I did the little trick at 15 minutes and I saw no appreciable response. So now what am I going to do? So in this kind of case, I really don't have a choice with easy labs to do. I could note that if my thrombin time's not responding, then okay, well, I'm not going to be able to do anything else laboratory wise easily to get something. So in this situation, I'm going to switch agents. Now, my APTT is how I manage the bivalirudin, and my APTT's not responding. Now, is this not responding because of the fact that the heparin was resistant because there's low antithrombin or some sort of other driver in the patient? Or is there also, on top of this, a laboratory issue? So I'm going to probably start the bivalirudin in this patient, and I'm going to want to do an APTT if that's what I have in a very short period of time to see if it's even responding to the bivalirudin. These numbers may be not at full anticoagulation response, but I want to know if something's happening. So this is one way to do it, because I need to make sure that I didn't practice in a silo and think it was a singular driver. I need to still keep the other drivers in mind, because at times more than one is present. In your lab, if you don't have the APTT and you're going to use this agent, you should know what kind of alternative approach to management is. Sometimes labs are using a dilute thrombin time to do this. So these are things to have in your thought process if you don't have both assays available. And then we're going to try to see and get a maximum response out of this and treat the clot until we can go to longer term therapy. So this is how I would go back and look at this case. So when exploring all this, the key points I want to make is anticoagulation is obviously a very important part when you have acute thrombosis, but also patients who have a history or high risk for thrombosis given the setting. we have to look at the lab as far as the measured response, and if there's a new thrombosis present and heparin is not responding, we need to figure out something to know that we're treating that clot. And this is a multidisciplinary process and it includes the lab. So it's really important for you to get out there and communicate and make your presence known because you hold on to key pieces of information that others don't. And if you have pharmacists, because this is kind of for Pharmacy Week, maybe take advantage of the situation and start creating a dialogue. How would the pharmacy call the lab instead of going through 3 or 4 individuals to get to the right individuals? Do they know who or what section of your lab is the best place to talk to so that they're in conversations with the subspecialist in the lab that is understanding the test and the process? I can tell you that when I wanted things right away because we were really struggling with stuff, I even took the sample as a pharmacist down to the lab, got it checked in because obviously it has to go through the laboratory process and such to be processed. But also then I had a dialogue with the coagulation specialists in the lab to know what the value was, and they called me directly so I could actually get the information and implement it right away. I can tell you that I've had neurosurgeons in the OR about to do a craniectomy that I had to hold them off until I got a result from the lab because we suspected something that was there. And so we got it urgently. And you imagine they're waiting in the operating room with a patient and they can't do anything till the lab reports it. But we knew how to get it to the right people at the right time. The decision makers is who it needs to go to. But again, if you have a critical value, someone has to see it. To me, this is not going to fit your critical value standards, but it is a critical value when nothing's responding when I need to have a response. The optimal approach and management is really a multifactorial decision support process, and it can be multiple drivers present. And so just don't think, oh, it's this, hence that must be. To me, an astute laboratory group would also sometimes say, hey, it's not this, it's not that. We have the sample here. Let's go ahead and look at these other things because this question is going to happen shortly and we have the sample here and we're processing it. And then that way you can see and provide insights sooner on what I can and can't do and what the lab is able to share. You're engaging and being more at the bedside than you think as far as managing these patients. And in development, we develop decision support tools and such in advance to these things so that we have good management approaches, order sets and stuff. The lab should be a part of this process because when we say certain things, if you want certain tests done in a certain way, if you get it into this decision support process, that helps. For example, when I do repeat labs, I try to coordinate it with the draw to make it easier for nurses. But when I do so, is that easy for the lab? Are the tests run at certain times of the day only? What do we do with send outs? All sorts of different things where communication is so clear. So I've tried to give this example the importance of the relationship. As a pharmacist, I respect what goes on in the lab and the information that you've taught me over the years and how we've collaborated. And in many cases, I can tell you that collaborated made a big change, and sometimes life-threatening issues were quelled down because of the collaboration with the lab and knowing what to do and how to approach it and getting what the lab needed. So if I get you the right sample in the right way and the right means, you can give me a better number instead of you working with garbage in the first place. So I hope you enjoyed some of the thoughts in this presentation, and I do look forward to knowing you are collaborating with my pharmacy colleagues, the nurses and the physicians at a higher level as a result of this programming that we provided to. And I also want to thank Stago for providing this opportunity to share this information with you.